All right, so I already see several participants in, and we are now live on Facebook. So let me go ahead and get started with some guest introductions here. First, we have Debbie Kimberg, who in my screen is in the top left. I'm not sure how it reflects for everybody else, but she is a mother of a son who's been impacted by Bartonella and autism spectrum disorder. She has written numerous blogs on the topic, including one for Project Lyme, and is working to encourage more research in the field. And she also just mentioned to us that she is writing a memoir about her experience and her son's experience with Bartonella and ASD. So thank you so much for joining us today, Debbie. We also have Dr. Amy Alford, who is an extensively trained integrative medicine physician who treats patients with complex health issues using a wide array of strategies for healing. She was recently appointed by Governor Greg Abbott to the Pediatric Acute Onset Neuropsychiatric Syndrome Advisory Council. In addition, she serves on the board of directors for ILADS and is their president-elect. We also have Dr. Ken Mitchell, who is a pharmacist and naturopathic medical doctor who has spent 20 plus years focusing on chronic infectious disease, environmental medicine, autism recovery, as well as Lyme disease and co-infections. Dr. Mitchell is also an ILADS member and past speaker. He is ACAM, Dan, and MAPS trained and is the medical director and co-founder of Nozzoni Functional Medicine. And lastly, we have Ryan Martin, who is one of the producers of the groundbreaking Lyme documentary, The Monster Inside Me. But he is also the founder and CEO of Arizona Autism, which has been serving the Arizona community and as a father of a son also impacted by Bartonella and ASD. So thank you all for joining us today. I think we can go ahead and start by kind of introducing the concept of comorbidity between Lyme disease, Bartonella, and autism spectrum disorder. So a brief intro here, and then I'll open with some questions, is Lyme disease and or Bartonella can share some of the same physical manifestations as those diagnosed with autism spectrum disorder. There are different variations of how patients may present given when and how an infection occurs. So this brings up a couple of questions for our experts, which I'll start with one. What symptoms exist in both diagnoses? And I think we can start with Dr. Alford for this.
Okay, great. There is so much overlap because the overlapping theme is really inflammation. So if you have neural inflammation from whatever the source, the symptoms can be overlapping. Obviously, there are issues with social behaviors, mood, cognition, intellect, capacity to function, overall executive function. And that's probably one of the reasons that this is challenging to address in kind of a usual medical setting. There's not a lot of time to dive in and really sort through how it started, when it started, what might have caused it, and get a lot of good background information, which I think, Debbie's done a really great job of sorting through their family history, and it was complicated for sure, and helped me be able to piece that together and taking care of them. But there's a lot of overlap, kind of like saying what causes fatigue. There's a huge long list. So those are to me some of the main symptoms. It's just anything that affects the inflammatory pathways in the brain could be a root cause, could be a variety of things, and oftentimes it's more than one thing.
Dr. Mitchell, is there anything that you had to add to that first question?
I would agree with all of that and more. The gut gets affected, the endocrine system is affected, the immune system is affected, and again, it's a matter of going down and finding the root causes behind them. And it's rarely that there's just one thing, and it's been rare that it's been genetic disorder. Happens once in a while, but
makes a lot of sense. Well, I think to continue through with this conversation, I would like to swing it over to Debbie and asking what different types of symptoms might you see in someone who's been infected congenitally, because I know that you have some personal experience with that.
Yeah, and I don't think of it the same way that our brilliant doctors do when system functions. I think of it in terms of symptoms that as a parent that we might experience with our kids. And so things that tend to show up through congenital transmission, so during pregnancy, not being able to make eye contact, not wanting to have touch sensitivity, not wanting to be held, maybe not developing speech, having issues in school, which Dr. Offit touched on, tics, dimming. These are all things that you would not think of as seeing in adults, but it definitely shows up in these kids. And there's really a pretty long list of all the kinds of tics that kids can have, and really improper social skills that just are not able to develop with the kind of brain inflammation that they discussed.
Now, Ryan, I know your son has also been impacted by both Bartonella and ASD. How would you describe his current situation? And do you know if it was congenitally contracted or from something later?
Yeah, I mean, a lot of this obviously is a guessing game, right? But our best guess is that we play the track back game, right? My wife has it, and then my son has it. So like our best guesstimate based on the stuff that we've done is that, yeah, it probably was from my wife, handed down through pregnancy, and that's how my son got it. And mine is just gonna tag on to what everyone else said. It's inflammation. Like when you're inflamed, like think about not even having a condition. Well, when you're something's inflamed, like you hurt your knee or you hurt something's inflamed, you're irritable, right? So like when things are inflamed, it causes all sorts of irritation. So like half the battle with all of, both my son and clients, right, is that behaviors, well, they're irritable. So that alone is a whole nother subcategory. And then the brain, if you have major inflammation in a gut and a brain, things aren't going to work properly and certain things are not going to flow right. And then it's going to impede development. And hence why you have so many delays probably throughout, with kids that share both.
Awesome. Thank you all for sharing. I think one last question to wrap up the concept of, how comorbidity even occurs in the first place is obviously we've discussed congenital Lyme that can impact development, but what other ways can patients contract tick-borne disease in a way that it may impact or potentially have some causality to developmental disorders and specifically autism? And I think I'll start with Dr. Mitchell for that.
So that one's right off the bat, tick-borne disease is like the, ticks are like the perfect vector to be transmitting so many of these infections, but it's not just ticks, it's also mosquitoes, fleas, gnats, kissing bugs, bed bugs, pretty much anything that can bite and transmit blood is able to transmit these infections. And most of these infections, again, can go through the placenta. So this is where the congenital part comes in for transmission. It's rare that you ever find a patient, whether it's a kid or an adult, that just has one infection when with these vector-borne pathogens. When it happens, great, much easier to treat. But whenever you find one, you better be looking for more.
Dr. Offit, do you have anything to add to that?
I think that's a great point. I do think a lot of people are tick bitten and they don't know it, and they're flea bitten and don't know it. They play at the park, they run in the yard, they don't have to have an engorged tick embedded for a certain amount of time to contract these diseases. And a lot of people think that's true, or they have to have a bullseye rash, and that's also not true. Like a lot of people don't know they've ever been bitten by fleas, but even the animals out in the yard, like squirrels and just wild animals around, have fleas. So when you have that mystery bite on your ankle, I do try to tell patients too, though, that it's a good idea to be out in nature just with a few precautions. And I almost look at this like a little bit like an algebra equation, where factor A is how healthy someone is at the time of exposure. Factor B is, what's up with their immune system. Factor C is how big of a load of the infection do they get at one time, and how many infections are they exposed to. like Dr. Mitchell was saying, a lot of ticks have more than one bacteria or other, parasites within their oral and gastric cavity when they bite someone. So it's overly simplistic to think that you would just get one infection from one bite. And then factor D is almost that other mystery factor of, what are someone's potential inflammatory cascade clotting factors? What kind of other infections are already pre-existing, which does affect your baseline health? And what has that done to the person's immune system? Because there are people that get tick bitten that don't get very sick. And there are other people that get one tick bite that have a lifelong inflammatory, long-suffering illness from it. So I think it's, there's so many factors to consider, which is what makes it a complex thing to talk about.
For sure. Well, thank you both for your responses on that. I think moving.
Hey, Noah, do you mind if I add one more?
Yeah, go ahead.
Yeah, so we talked about congenital transmission, and I think we're thinking a lot about it can go from us as maybe the father to the mother to the child, or from the mother to the child. But in my case, we've got 3 confirmed generations of tick-borne disease with 100% transmission of Bartonella, Borrelia, and Babesia in every generation. So, you may not have been bitten by a tick. It might already be in your family and you just don't recognize it because people just might experience some psych symptoms. So they might just have OCD or emotional lability or maybe anxiety or depression, or maybe an autoimmune disease like thyroid, and you just would never think anything of it. That just seems like, general health of everybody today, but it could be something more.
I think that's a perfect segue into our next segment, which is identification and treatment. Is clearly, you've done, as Dr. Offit mentioned, Debbie, a large delve into your own family history, which helped you to more easily identify the potential of these diseases. But there's a lot of people who may not know what steps to follow or what the benefit of that could be. So I think first, I'm curious to hear from our doctors on the panel, ways that you've personally identified as patients and maybe some of the ways that you've been able to treat them with things such as antibiotics and maybe what time period to see any sort of results. So Dr. Mitchell, I think I can get started with you with the more specific question is, can you elaborate on your treatment protocol, such as what type of antibiotics and over what time period you typically work with?
Well, I think you first started out with, how do you make a determination to begin with? And really the first best is to take a look clinically at the picture to be able to see what kind of symptoms you have going on so that you start to be able to figure out, what do I need to look for? If you have a child that's got a lot of rage and anger, then maybe you should be looking at things like West Nile virus and toxoplasma being present. If they got a lot of excessive weakness going on, perhaps you need to be looking at Francisella and Brucella being in the mix as well. The labs depends on which pathogen you're talking about. Some of them are relatively easily picked up no matter which lab that you use. Other ones such as the Borrelia, Babesia, Bartonella, some of the rickettsias are much more difficult to pick up. The local labs typically miss it. And especially when you get into states such as I'm in here in Arizona, like Dr. Offit in Texas, that you'll have physicians that are not Lyme literate, that don't understand that these pathogens are in all 50 states and over 60 countries worldwide. And they'll say, oh, you can't have this stuff. And so you do the local labs and it comes back as negative and it gets dismissed. The labs that I use depends on the patient, if they're able to exercise, so we can get the pathogens moved out of the tissues, out of the muscles, out of the joints, into the circulation, then you can start doing things such as a urine PCR test. I don't know if we're allowed to say companies on here. I have no affiliations with any of these lab companies, but the urine PCR test is, if it picks it up, it's pretty definitive that it's there. And there's other ELISA type labs that have come a long ways that have a much better detection than the original labs that started doing this. There's some overseas, such as RED Labs, which uses a whole completely different type of mechanism to detect, and it's very good, but it's only for Borrelia. But the worst testing you can do is the local testing. Your typical LabCorp Quest labs are the least sensitive labs out of all of them to do. And historically, the old timers, they used to have to retest patients 3, 4, 5, 6 times before they would finally come back with something. Like I mentioned before, if you find one vector-borne pathogen, then you've got a pretty good suspicion that there's others there. And if you use the symptoms, then you can start to figure out what you're probably dealing with.
Awesome. Thank you so much. It looks like we are already getting a couple of questions in, and I don't want to go too far past the concepts related to them. So I saw we have an Elise in our chat here. She asked, what is the evidence behind passing infections congenitally as a parent or as a pregnant mom when infection isn't active or in remission versus active? Is there a difference in risk? Now, I am not an expert, but I know that the research here is still relatively new. Is there anybody on our panel that has a good gauge as to how they might be able to approach answering this?
I'll take a stab at it.
Sure.
Charles Ray Jones was one of the pioneering pediatricians in the ILADS community, and he had many documented cases where he had them take actual cord blood from the, there's no possible tick bite or any bug bite for a brand new baby when you're drawing cord blood, where he showed basically that congenital transmission was possible. He also demonstrated that if he were able to work with someone to give the mom some type of medication during her pregnancy to suppress replication of really, I would say this is mostly directed specifically at Borrelia, which is the bacteria that causes Lyme disease, the spirochete, that there was a lower level of transmission. All of that, as Dr. Mitchell mentioned earlier, is debatable. Like there's groups of thought out there that say that this doesn't even exist in a chronic form. I think that's very easily arguable if you really just go look at the actual scientific information that's out there. If you're seeking that information, it is out there. And I think testing, as Dr. Mitchell mentioned earlier, testing makes it very challenging. Say you test a baby when they're a month old and they're negative, but the testing that's often used is just antibody testing. So antibody testing is not very reliable from a regular standard lab, to piggyback on what Dr. Mitchell said, because really the testing that's used through like Quest or LabCorp or CPL is epidemiologic testing. So it's meant to be used for a broad sweeping patient sampling across, a large state to get an idea of how many cases there may be. And even within that, it's not meant to detect, it's really meant to under detect questionable cases. And if I have somebody sitting in my office and I'm trying to diagnose that person, I don't want an under detecting test. I want a very sensitive and specific test that helps me rule in and rule out things, which we don't really have. So clinical suspicion has to be high. And if I have a pregnant mom in my practice who's had Lyme disease, there are some ways that you can, besides clinical history is the most important, most reliable thing we have in our toolbox. But if you check some inflammatory markers, sometimes those will be a little bit of a indicator. If someone was treated long ago and they've been really healthy for a long time and then she gets pregnant, her odds of having any problems are a lot smaller than someone who, say they're treating actively and they become pregnant. That person, I would worry a little more about congenital transmission. And then a lot of that is still, I would say, a little bit up in the air for documenting it in large numbers with things like Bartonella or Babesia. Even though, the other thing, just Debbie earlier mentioned congenital transmission. The reason that's been somewhat hard to prove is we live with the same people that we give birth to. So like my kids and I play in the same yard. We go to the same travel destinations, and where did it come from is a question that people do sometimes debate. And at the point when you have it and you need to treat it, it doesn't matter as much, but for other people to understand it, those are good things that we could be researching.
Awesome.
Dr. Amy, real fast, because I know that this is something that parents would definitely ask. Like, you made a comment in the beginning that there is something that sometimes people take while they're pregnant that feels like it lowers transmission rate. I guarantee there's parents that want to know what that is, or more, or an area they can research more about that.
I usually use antibiotics because antibiotics have some data on their safety in pregnancy. That's a conversation we have, and we go through the risks, the benefits, the pros, the cons. I don't treat every pregnant woman who comes in if she's afraid she has it. A lot of times people just need close monitoring and close reassurance. I always do it with the OB-GYN because I want the OB-GYN measuring, fetal growth, looking for all the biometric markers that you use to make sure the baby's healthy. But I don't have any hesitation if I have a mom that I feel like she's high risk for giving her an antibiotic while she's pregnant to lower her risk. I don't do a whole lot of that, but definitely when it pops up in my practice. I've had some of my patients I'm treating for Lyme get pregnant, and I definitely keep them, if we're not done treating, I definitely keep them on something through their whole pregnancy just to cut down on the risk of the baby. And I have never had any issues with that. When the baby's born, I always follow up and check in and ask, how's the baby? And those babies do great. So I think, we're missing that opportunity. It's not like I'm a huge fan of antibiotics. I mean, I'm an integrative medicine doctor. I like to use them as a last resort, but in certain circumstances, when that's the best option, then that's the way that I usually proceed.
I would echo that too. And there's antibiotics that I'll use, and there's antimicrobial herbs that I'll use, and they have to be researched out to look at the risks. And again, it becomes a risk-benefit assessment at the time for the individual. But there are medicines that can be used, and I have treated them.
Great follow-up question, Ryan. I'm going to come right back to you, actually, and Debbie after, and saying Dr. Mitchell and Dr. Offit spoke a little bit as to how they as providers may identify these diseases in the children that they're working with. But what about the parent perspective? What led you, Ryan, maybe to start beginning to see Dr. Mitchell or take next steps to become CEO of Autism Arizona with your own experience?
Are we talking about the Lyme portion or the autism portion with my son? Because
I would do your best to speak to both, just given that we're trying to cover all bases here.
So for me, obviously, there's a lot of unknown factors of the autism thing. Like, both these two topics are two topics that don't have like this super big concrete data. Both categories I'm in, it's like there's these, where did it come from and how did it and all that and whatnot. So I'm only going to speak to my personal story. That way, there's some people that get a little upset about when you talk about the vaccine thing. So I'm not giving my opinion. I'm telling my personal story. My son, from the age of 0 to about 14 months, was 100% normal. I mean, normal as in hit all normal growth, hit all talking, walking, did all the things a baby should do. There was 0 delay. When my son got his 1-year vaccines, he had what's called a major adverse vaccine reaction. My son spent 3 days with a crazy high fever, acting psychotic for 3 days. We called the pediatrician every single day. Every single day they said, you're fine, you're fine, you're fine, right? So as first time parents, we did what we did. After about a week, when that subsided, my son began to lose every single ability that he had, talk, walk, so from that, it changed the trajectory of our life. Now, do I believe that the vaccines gave my son autism? Absolutely not. That's not what I'm saying. I believe that my son had autism genetically through whatever it may be, and that the vaccine was like a perfect storm. He probably had like a cold, an immune compromise, maybe Lyme, all that stuff together, and bam, all together, that created an adverse effect that jump-started the condition inside him, whether that would have been Lyme back then and autism or whatever it was. And that later on down the road, when my son got older, that's when he become extreme in the behavioral route. And when we were searching for answers of, okay, this can't just be autism. He is like really having major stuff. He eventually had to be checked into a pediatric psych ward for a stent where they had to go through all the different testing, try different medications. And that's when he got balanced out. That's when we started really looking for deeper answers, which then eventually through the Lyme world led us to getting the testing done. We got the big aha moment. We're like, oh my gosh, it's not just autism. It's a combination of the Lyme disease and the autism combined together that is causing such an inflammatory response of why he's literally popping off and having such hard issues in all facets of his life.
Yeah, I'm sorry to hear that has happened to you and your family. I'm glad that you've made some positives out of it, running your own organization that's helping other families that have experienced similar to you. So great on you for that. And thank you for sharing your story. Hopefully that helps other parents that might be listening to potentially see in themselves and take next steps to further understand their own child's situation. So I'll now swing it over to Debbie, kind of exact same question, talk about your family's experience and kind of where they are now.
Yeah, thanks. And Ryan, it's probably good that you and I are both here because we have such different experiences, just to let everybody see how differently this can happen in a family. So when my son was born, everything seemed fine also. I think the first thing that we noticed was a neck roll tick. When he was 6 months old, he would just go like this. I don't know if it's stimming or a tick. But then he made eye contact. He was very social. He loved to hug. So we didn't have any of those types of issues right away, but just over the years, more and more odd behaviors came on. And so he had more and more tics. He was squealing sometimes, he was grunting, sometimes he was flapping his arms when he was happy. He had learning disabilities. He really struggled in school. He was uncoordinated. And, we took him to lots of different therapists, and somehow we stumbled on a doctor when he was 10, and that's pretty much what happened. We stumbled on it. We didn't go looking for it. And she did a quick intake interview and said, hey, I think your son has PANDAS. And I think that's how a lot of us start out, or PANS as we call it today, that we get that initial diagnosis with those really simple tests that you can get through LabCorp. And he lit up strep, and one of the second worst cases that the doctor had seen, and so it confirmed her quick diagnosis after a 30-minute intake. And we thought, boom, we've got it. We know what's wrong. We're going to treat. He's going to really come around. And that's not at all what happened. And his behaviors continued to evolve, and he would become OCD, and he got OCD. He became oppositional, very difficult, argumentative, antisocial, just want to be in his room and play electronics. None of the medicines were working. Either they did nothing or they made him so oppositional. And so we struggled for years and years until, thank God, we moved to Dallas and met Dr. Offit, and she really helped us figure out. And we did have a Lyme diagnosis years before, but we just couldn't get the right treatment. And that was so key. And Dr. Offit really helped us figure that out.
Awesome. Thank you as well, Debbie, for sharing your situation. I see a lot of questions coming in on the chat. So I want to segue real quick into sharing some information and trying to answer a question for one of our guests here. So an article was actually published last week by Helio that shared that researchers estimate that the prevalence of autism spectrum disorder among children and adolescents was 3.49% in 2020, which is up from 2.79% in 2019. First, my question would be to people on the panel is, do you feel the increase in these cases coincides with the similar increases in Lyme cases that we have seen? And then following up on that, I will ask the question from the audience. And whoever would like to start can take that.
Well, I'll take a stab at it first. First off, about 40, 50 years ago, the incidence was about 1 in 10,000 kids. And so, now it's what, 1 in about 44 kids. You can talk about genetics, but there's no such thing as a genetic epidemic. You can't have the human genome change that quick. It's an environmental issue. So is the environmental part the infections? Is it the 87,000 plus toxins we have in our environment now we didn't have 100 years ago? Is it is it so many other environmental factors that we run into, not just Lyme. You have to look at all of it in order to make an assessment here. With my own son, I found heavy metals. I found pandas. I found the infections. Of course, that was later because way back 20 years ago, there was no connection between the two. We didn't know anything about that. And there may be, again, genetic predispositions. There could be nutrient deficiencies that will contribute to all this. Lots of different factors to look at. I don't think that this increase is due to just being able to diagnose this better. It's a convenient excuse. It's not true.
Awesome. Does anybody else have anything to add?
I'm 100% with everything he just said. I believe the 3 different things, right? It is everything that's in your environment, right? It is everything you put into your mouth, right? Your body. So all of our foods have the same contaminants that are out there. And then for me, once again, just so I point out, because I'm going to start sounding like an anti-vaxxer here I'm not an anti-vaxxer, but we had 18, I'm 40. We had 18 vaccines when I grew up. There's 72 now. There's a lot to that many more metals all going on to your body at the exact same time. There's some things that have changed a lot in the past 100 years about what humans are around, what they take, what they do from both skin, mouth, body, injected, everything. So a lot has changed. I also do believe that there's better testing. And more testing, it's aware, but that is not, just like Dr. Mitchell said, that's not the main thing. That just adds to it. Like when I went to school, there were tons of high functioning people that I remember now that I know about so much about autism. I'm like, oh my gosh, so-and-so is autistic. Like I know so many people I grew up with, but back then it wasn't a thing. So there's definitely more, but the percentage of that, it's not like, oh my gosh, we're just aware of it now. It's everywhere. It's not that. There are things changing around us that are increasing for sure.
I'll say one more thing about that. One of the lost arts of medicine is listening to patients, listening to parents. Like when I was a resident, I was taught that there's certain things that parents are going to say that they're not true. So just don't listen to them, which is really sad because parents, I'm a parent, I have 3 kids. Parents know better than anyone what's going on with their kids. They know the timing, they know what their kid ate, where they slept, what they drank, what shots they got, like what medicines they took. And if we just would go back to really basic medicine and say, like, sit down, take the time, listen to each family, to each parent, what happened, and stop like shutting them down or shaming them or disregarding their history, that would be a huge step in the right direction. Like instead of labeling people, I'm pro-vax or I'm anti-vax or I'm halfway vax or whatever, just shut up about that part and listen to the patient's history, listen to what happened, listen to the story, and look at the child and examine the child. And I mean, people don't want to nobody's making anything up. So like, I mean, I can get labeled a bunch of ways too. And I don't care about that. All I care about is patients. And so the way we make forward progress is we continue. What we really need, you guys, and I know this is not really what this is about, but we really need funding in actual research data. There's, ILADS has been wanting to do like a big data project. There's other people out there that say they want to sink some money into the research, but then they attach so many specific criteria that it just doesn't move forward. I think there's a lot of interest these days in doing more research, and we just need research with published, like bigger. We've got a lot of small research published, but we don't have like a big reference that we could refer. It's going to be hard to get it published too, because of all of the pressures against it, but especially now. But just going back to really basic history taking, clinical evaluation, who cares if the lab's positive or not? Treat the patient, like look at the patient, listen to the patient, diagnose the patient, and treat the patient. So sorry, I'll stop with that, but I hear what y'all are saying and I totally agree with you.
Awesome. So thank you all for that. To actually follow up with the question from the audience, it's from Ashley. I know we spoke kind of on the identification side, but through this, she has seen this massive increase in autism and in Lyme, and was curious if there's something that's a part of a routine obstetrical testing that she may be able to look into that would allow to better identify if an individual can congenitally give their child Lyme disease or any of the comorbidity with ASD. And I'll bring it right back to you, Dr. Offit, if you are okay with that.
So I have a colleague who is a pediatrician who actually does, we actually have plans to get together and sort of share something she recently learned when she was at an autoimmune encephalopathy conference about specific HLA genotyping patterns that she has even mentioned, perhaps adding that to like the newborn screening that's routinely done on all newborns. Like here in Texas, it's a heel stick before you leave the hospital, a blood blot, and then another one 2 weeks later. And it's really meant to catch things with which babies are born that usually in the past, if you avoid certain foods, the baby's neurologic development will be normal, versus if they're missing a critical enzyme that digests or breaks down a certain food component and they're missing it. If you don't feed them that food, then they develop normally. But if you feed them the food early, they can have some permanent nervous system injury from it. That has been expanded quite a bit, the newborn screening for babies. And so, it's arguable, but a lot of this all overlaps back with, chronic inflammatory response syndrome, which has somewhat traditionally been considered related to mycotoxin or mold exposure. Although, the person who's published most on that also says that tick-borne disease or bites or other exposures could trigger the same cascade of inflammation. And that particular syndrome has a genetic predisposition. And I'm not saying these are equal, but I think if you stack them all together as a predisposing factor, I don't think we ever will routinely check that on pregnant women or on newborns, but definitely if a newborn has an older sibling who's had some problems, or if a parent just has a really high suspicion for it and wants it, I don't think the testing even costs that much. I think it's less than $100. And so I'm not saying that's the test, but there is definitely where things start is with a little critical thinking and some hypothesizing. So if we hypothesize that people with these HLA types develop chronic inflammation, we should, I mean, that would be a great study. Like, what do we take a subset of children, check all of their particular genotypes with regard to this? And Dr. Mitchell, you probably know more about that than I do even, but like starting to look earlier and then avoid earlier. And the whole thing's, it's a stacking of toxicities or a stacking of pathogenic exposures. And if you get enough of them, at some point you tip over into like a chronic inflammatory disease, whether it's rheumatoid arthritis or PANS or, Hashimoto's. If you start tracing it back, like there were some initial insults and then more insults stacked on top of those that created the patient's inflammatory burden. And that's where we have to work our way backwards, like looking at each thing that's wrong and treat each thing until we get as much of their process reversed as we can. Do you have any other thoughts, Ken, on like the genetic part of like what a mom could do as far as getting her child's genotype tested?
Well, the easiest just for would just be to do a 23andMe and then run the raw data file through something like NutriHacker. You can run a carrier report as well as a complete genetic report, and you can see some of the basics there. The HLA-DR is very nice for taking a look and seeing if they have polymorphisms there that are going to cause them to have difficulty offloading toxins. If they're and fighting off infection. Looking at it's really going to depend upon what you're presented with. Are you looking at a prospective mom? And screening her ahead of time, fantastic, let's do it. If this is an after the fact where you've got a challenged child and then you're now having to take a look and see where's the cause, and then you talk with mom and if mom's got one of the over 300 different disorders that look like Lyme and the co-infections, then start taking a look there first, and work your way on through. Sorry, I couldn't give you a better answer than that, but everything's different. Mold mycotoxins, environmental toxins. We now have some good labs that are companies out there to go look at those levels. Just simple urine tests, find out if you got burdens on board. Those are just some of the challenges, but for the infections, yeah, you're going to have to do the labs.
A good follow-up to that, and I see there's a lot of questions in the chat and a lot of questions in the Q&A, and I'm going to apologize now because I can guarantee we're not going to get to all of them. I know some of our doctors on the panel have some patients that they're going to need to get back to. So we have about 15-20 minutes left. So I want to move forward here as like a major takeaway for everybody on the panel at the moment is, should all children who have been diagnosed with ASD be screened for Lyme disease? And I can start with Dr. Offit for that.
Yes. I think they should all be, honestly, they should all have a very careful history taken, including their mom's health history before birth, before they gave birth to the baby. And then based on that history, they should have a carefully implemented testing regimen. Not everybody can afford all of these tests at once, and not everyone has enough blood and urine to do all the tests at once. So the reason that, like, I teach some doctors how to work these patients up, and you have to use your clinical judgment to know where to start. So what stands out the most? Does the child have a lot of rashes and allergies and hypersensitivities? To me, that child either is more likely to have Bartonella or perhaps a mold issue. than some of the other infections. The other ones are possible. I don't rule them out, but it might make me start first looking at those particular pathogens. Some patients come in and say, like, test me for everything. I don't care how much it costs. You know, like, I still wouldn't say that we should do that. We still have to carefully start and work our way, because you're not going to treat them for everything you find right away either. So start with what stands out the most, which is different from patient to patient. You know, the first year I went to ILADS, the moderator said, if you're looking for a cookie cutter regimen to treat patients, you can leave, because there's not a cookie cutter regimen. It takes practice, it takes observation, it takes working closely with patients and following them. So like, if you have a patient on a therapeutic and then the mom calls back and says, this isn't doing anything. After 3 months, it's not changing anything, we should change therapeutics. Versus if someone calls back in 2 weeks and says, you know, my child is talking a little more and seems a little more bright-eyed and a little more inquisitive, that tells us something. We should use that information to continue pursuing whatever it is we're treating, maybe treating it even a little bit more aggressively. So I use a lot of parent feedback to make decisions as far as changing directions or deciding on therapies, because there's a lot of therapy options too. So some kids can't take antibiotics at all. Like, it just makes them have digestive issues or bad yeast infections. Other kids, it doesn't seem to faze them and they can tolerate them very well. So individualizing the care for each person is what's kind of time consuming, but it's where the real treatment happens, in my opinion, in my practice.
I would echo that. You've got to meet the parents and the patients where they are. That you know, you prioritize your testing. You know, you can pretty easily rule out a lot of the metabolic issues with just a simple plasma amino acids test. You know, after that, you can start looking at autoantibodies. You can do neural autoimmune testings. Number of labs, even LabCorp's got some of them now. You know, the Lyme testing, and you know, looking at some of the what I would call the canaries in the coal mine, just doing something simple like an Epstein-Barr early antigen to see if it's active. Looking at CD57 and see what the immune system is looking like. Just those two alone can tell you if their system's challenged, and then that you need to be looking further. And after that, then it's, you know, do the Lyme testing, do your food allergies, do your you know, MMR, IgM titers, you know, things such as that, and in your environmental tests. And
Dr. Mitchell, I'm going to come right back to you with this, because I think it's a great way to move it a little bit forward. Can you speak to your experience of any recovery? Not necessarily cure. I know, especially in Lyme disease, and I'm sure in ASD as well, you know, it's good to stick away from the word cure, but have you seen in your patients a recovery, remission of symptoms, decrease of direct impact through some of the treatment regimens that you've utilized? Absolutely, frequently. You know, I never use the C word in my practice. You know, the C word tends to be absolute, is like 100%. It's like, well, my kid's 99% better, but he's not cured. It's like, okay, 99% it's not good enough. Okay. So, yeah, well, my own son, you know, that he was diagnosed by Melbit here, that we were going to institutionalize him. And my ex and I didn't say no, we said H no. And that kid right now is 21. He's on a scholarship at ASU in engineering. And he's neurotypical. But you know, back in the day, you know, he lost all of his language, was beating his head on the floor, screaming inconsolably, and worse. Can you get recovery? Yeah, I've seen it. That was patient one for me. You know, as far as for my Lyme patients, I've got many of them that I can get off the antimicrobials in as little as about 8 to 9 months, and have resolution. But I've got to use the newer disulfiram treatments, but I have to do a lot of protection
to protect the mitochondria. In the process of doing that, before you can do any of that, you've got to support the patient, because so many of them come to you very toxic to begin with, and you can't go and start killing off pathogens and releasing more biotoxins into their system when they're already overloaded. So this is part of what Dr. Offit said. It's got to be individualized treatment, that everyone is different. I'm very grateful for my background, because I started out as a pharmacist and got the allopathic training, and then I got the naturopathic training after that. So that I get a bigger toolbox to work with.
Sorry, Dr. Mitchell.
Go ahead.
Just one other thing to add, and just based on my articles or having friends who've gone through this, I've just heard from so many moms, and they said, how do they get their kids tested? And the first thing that I always do is ask the mom, do they have symptoms? And I'll send them the symptom list of, psychiatric, autoimmune, might have digestive issues, gluten, dairy sensitivity, things like that. And almost 100% of the time, the mom will say, oh my gosh, I have symptoms on that list, and I had no idea. And so these aren't people that you usually hear about in the Lyme community who've been the most vocal, that have terrible chronic pain. They can't get out of bed, they're disabled, they can't go to work. These are very high functioning people who have, a couple issues that, again, we just think, hey, this is just typical health for us, for Americans these days. But when in fact they really have what I call a stealth infection, and they don't realize the kind of damage that it can do if it gets past your children in utero. So I couldn't agree with Dr. Offit more. Like, we should be testing every single child with ASD, because what we don't know is how many of the kids are infected. And I could see very much creating sort of the MSID, I don't know exactly the right way to pronounce it, but Dr. Horace's screening of symptoms and scoring, because I think if you give that to the parents and they take a look at themselves, their spouse, their kid that has autism, or their other children, it might be a really good diagnostic tool to help providers quickly recognize who might be at high risk.
Well,
Thank you.
like Dr. Offit, if you listen to your patient long enough, they'll tell you what's wrong. So, there's sometimes they'll come in with pathognomonic symptoms. In other words, telltale things such as they've got inflamed striae that look like tiger scratch marks on their back. And it's like, okay, there's nothing else that's going to cause this. It's Bartonella. Or they've got muscle and joint pains that wander and travel around. And it's like, okay, there's Bartonella, there's Babesia. There's nothing else that's going to cause that. After that, then when you start looking at co-infections, then it's a little easier. But with Borrelia, with Lyme, that's looks like over 300 different things. And I've seen all the different well, as many as I want to see of the different permutations that are out there. And you can't always pick them out from a symptom list. But testing, yeah, do it.
I'm glad to hear that everybody is on the same page with that. So it definitely reassuring that we at least have a good group of doctors who have some sort of a gauge on how to make some process here. Yes, Dr. Offit.
I just want to say, because I feel like this is a really important point, I say yes to testing, but don't put all of the weight on the testing results if you're using especially like regular conventional testing, because I've seen that done so many times where people come in and they say, kind of like Debbie did earlier, we got tested for Lyme, it was negative. Well, who tested you? How'd they test you? What was the method of the test? Because if it's not very reliable, we shouldn't be leaning on it so hard. So just be careful. If you are suspicious, you want to get your child tested, make sure that the testing is like a good quality test, and or like I just recently started in my office I bought a really nice microscope, and I'm pricking my patient's ears and looking at it. And, you know, when I first started, I felt like a long time ago, I worked in a chemistry lab and a urine lab for like 6 months. So I had a lot of microscope past experience, but not looking necessarily for what I'm looking for now. And after the first probably couple of weeks, I started feeling and seeing, patterns of what's normal, what's abnormal, what stains. And I'm not using those to diagnose my patients, but if I see a smear of blood, it takes like not that much time. See a smear of blood under the microscope that stains for intracellular erythrocytic organisms or little bacterial organisms kind of on the edges of this red cells. Like that actually is something. And then it just tells me I need to kind of go after that. And using it in the context of the clinical presentation too. So every little bit of data matters so much more than one test. So even though I think these kids should be tested, I think they should be tested, and then that test should be considered in the context of their history and their clinical presentation.
Absolutely. A Western blot is designed to not detect, but there's bands within there that are specific for Lyme. And so you start seeing any of those specific bands coming up, then you need to look further. Just for the Lyme.
Yeah, and my little nod to both Dr. Mitchell, obviously I'm biased, but doing the movie over the past couple of years is this. It is super important, not just the test, who you're with. Like if you're starting this journey out right now, make sure you go to an eye-led doctor that has crazy good reviews, that people talk up and they have a track record. Like to me, that's an important thing. And I'll be honest, we did a lot of research. There's not a lot of them. It's why people in certain states go to other states to find the doctors. Make sure you are not doing the fly by night, your own test, your own thing, the random, hey, I kind of seen a few people with Lyme before. That is not who you want to have this stuff done through. You want to have it done through doctors like they're on this panel. Find people like that. That's going to be your greatest chance to one, getting accurate results, and then the appropriate treatment accompanying after it.
But we actually have like a physician training program where we try to place anyone interested with someone that's got more experience so they can, we do it virtually or in person. I love doing that. I've had a few this year already. Doctors that just come and sit and listen and learn. And then we do follow-up patient cases so I can help them, because we need more doctors who, like, really, to me, I know there's a lot of doctors out there with compassion, but if you really have a compassion for your patients, you can't help but learn at least to look into this, because otherwise you can't help people get better. So if you have a heart for getting your patients better, like this is something that I think a compassionate doctor out there. And I promise you, like Dr. Mitchell and I, we do some things the same, we do some things different. I know I have a lot of treatment successes, but I also have treatment failures. And so sometimes I'll see someone that I haven't seen for 5 years, and I do things differently now because I've learned more now than I knew 5 years ago. So like we all kind of have to start somewhere and learn and share and grow. And like for me, my dream would be to build a bigger network of compassionate, caring physicians and clinicians who want to get these patients well. Because, if they just start with a process, like a little bit of mentorship and a process of try, this and this, and then follow and see how the patient does. If it's not working, don't wait very long, shift and do something different. That's how we all learn. We all go through many years of training, and during the training, we're treating patient after patient after patient, and that is cementing in our mind, like the approach. And so this is a different approach, but it's a meaningful, actually, so many doctors are burned out because right now, a lot of it is cookie cutter, quick in and quick out, treat them and treat them. And that's really not good care. So if, anything from me selfishly from a takeaway today is, if you guys know doctors who are interested, they're just intimidated or they're scared, like if they would just reach out, like they can reach out to me, they can reach out to ILADS. Like there's a desire to get more people trained so we get better care and whatever, whatever that looks like. I know right now, if you go in a big room full of doctors and say Lyme disease, a lot of them like roll their eyes and turn the other way and don't want to hear about it. So really we're trying, at least I'm trying to approach it from like, what about your chronically inflamed patients? What do you think is really wrong with them? Start the conversation there. And then once you get the conversation rolling, then we can actually introduce the root cause concepts that we are talking about today on this webinar.
Awesome. Thank you so much to everybody who has been participating to this point. I will say we're at 6:30. I personally have about 5 minutes left, and I want to wrap it up with Debbie, who is the genesis of this entire event. She was the one who wrote a great article for us and shared a lot of great experiences. So I personally want to ask a question that I saw here in the chat to you, Debbie, to say, address your experience of how these diagnoses have impacted your family and provide some of the advice that you may give to parents on how they can cope with some of the more severe symptoms that they have seen. And then I would also love for you to share some of your resources that are out there.
Yeah, sure. Well, we didn't really have an easy story, and I think that's true of a lot of folks because it takes so long to get the right diagnosis. Dr. Offit mentioned it's really easy for the testing to lead you astray. And for us and for everybody in my family, Bartonella particularly was the driver of so many of our symptoms. And I have one child who had a positive test for that, but it really took a lot of work and working with Dr. Offit to figure it out. And so, be patient because it will take time. There will be trial and error. Do find a good doctor. And if money's an issue, if travel's an issue, I've definitely helped other moms work with their doctor and call Dr. Offit to get consultations, to get training. And so, we definitely need to expand that network so we all have doctors in our neighborhood. And on a personal note, I got a lot of pushback from my entire family that, especially when my son didn't respond to treatments right away, that this isn't him and I'm crazy. I'm the crazy kid in the family, and including my husband and my own kids. And so, don't be beaten down by that. If you are even seeing small improvements and you believe this is what's going on, just stick with it, keep working with your doctors until you can get the right treatment that's gonna make a difference. Everybody will come around with results.
Awesome. And then do you want to also want to speak to your Instagram page and your website as some resources that are available to those who might need more information after we end this session?
Yeah, sure. So you can find me at Hijacked Brains on Instagram, and I'm just kind of narrating not only my child's story, but just really key information that I think is important for all parents to know so that they can identify problems and go seek treatment. And I also just launched a website. It's called debbiekimberg.com. So easy to find. And if you are interested in my memoir, when it gets published, please sign up. I'll let you know when it's available. And I also added a research link, which gives sort of the basics about all of these infections and how to think about congenital Lyme disease and differences between symptoms in parents versus kids and similarities too, as well as my favorite blogs and research articles. So hope everybody finds that helpful.
Awesome. Thank you, Debbie. And thank you to Dr. Mitchell, Dr. Offit, and Ryan for joining us today. I will make sure for all of those who are participants, this is being recorded. So tomorrow, the plan is to send out to everybody who is registered this video recording if you want to watch it back. There's a lot of questions that I know were asked in the chat that were answered in the conversation. I will also make sure to include Dr. Mitchell's and Dr. Offit's practices, as well as Ryan's, is it Arizona Autism, correct, Ryan? Yeah, I will make sure to include links to Arizona Autism as well for people who are located in those areas to take advantage of the resources that are, as Debbie put it, in your backyard, close to you. And hopefully, as we continue to have these types of conversations, the education will continue to spread across the nation, and ideally, we'll be able to serve people in the best possible way, provide the best possible care anywhere that it may be needed. So thank you again to all of you for participating, and I can open it back up if there's anything else anybody wants to say before we conclude this session. Awesome. Thank you again. Thank you again. Bye-bye.
Thank you.